That is the first stage. This, I think, is in your book too, so if you don't want to, copy this all down. Partial thickness is a stage 2. There is skin loss that involves pretty much just the epidermis. It might go down slightly into the dermal layer, but not very far. Full thickness means that you are all the way down through the skin into the fat layer. So you will see visible fat. A stage 4 is all the way to the bone, the muscle, or the tendon. And we've got some pretty good illustrations of those in the lab that you'll see when you come to lab this week. So the clearinghouse is the National Pressure Ulcer Advisory Panel. If a patient has a suspected deep tissue injury, it is unstageable. And what that's going to show up as a purple or maroon area. It looks different than a bruise, and I can't really describe it to you, but I think that will be an aha moment for you. The one thing I can tell you is that different than a bruise, it will feel boggy. When you touch the skin, it normally kind of gives a little bit and comes right back to level. Well, in this, it's very similar to a patient who has edema. You touch it, and it feels like you're walking on a swamp.
Like a bad tomato?
Like a bad tomato. That's a good description. Okay? That's what it will feel like. Okay? Exactly. Toss it.
Yeah, I'm like,
yeah. Well, that's what this is like. And that is unstageable because the piece that you're seeing, the bruisey maroon part you're seeing, is probably this big underneath. It probably goes like this. It is a big hole all the way down to the bone. Okay?
That's on the surface of the skin, so it hasn't broke through the skin yet?
It has not broken through.
And it's going to feel like a yucky tomato?
Yep, it'll feel like a yucky tomato. Absolutely. Or like walking through a swamp, it just doesn't, it feels boggy. Okay?
Which stage is this?
That is a suspected deep tissue injury. It is, you can't tell because it's not open. Okay? So it's unstageable. So anything that would be covered with necrotic tissue, that black leathery stuff, or anything that is this kind of a purple boggy feeling bruise is unstageable. We can't stage it until the surgeon gets at it and takes all that stuff off. Okay? In most cases, they're right to the bone. Okay, they are not a good thing. Granulation tissue is red, moist, beefy looking tissue. That's what we're trying to get the wound to look like to get it to heal. We want it there so that it can start to heal from the bottom up. Slough is the yellow slimy stuff that you see on the wound. S-L-O-U-G-H, slough. Yellow, slimy, that's slough. So many wounds, when we first see them, will have an area of necrotic tissue. They'll also have some areas of sloughy tissue.
Is that similar to, like, if you pick a scab that is not fully healed yet, that yellow stuff next to it, underneath the, is that
Slough.
slough?
Yes. So let's see, in your book, diagram 48-4 on 1180 shows you pictures, I believe, of these stages.
I got it.
So, eventually, and I don't expect it at this level, but eventually you are going to have to be prepared to look at a wound, classify what kind of a wound it is, and then be able to come up with a plan for how that wound is going to heal. Now, both Saratoga and Glens Falls hospitals have wound care teams. At Glens Falls, the routine is that every Wednesday, the team gets together. There's usually 2 nurses working in tandem, and they visit every patient on their unit. So for medical services, they'll have, let me see, what's 46 and 24?
46 and 24, 70.
So they'll have in excess of 70 patients. depending upon how full one of the units is. And they will see every single patient. They do a head-to-toe skin assessment on every single patient, regardless of their age or their diagnosis. Even if they're young patients, they have the discussion with them about how important it is to remain mobile in their bed and to keep their heels off the sheets. Keep their heels elevated off the bed on a pillow, for everybody. With the idea being that we prevent pressure ulcer occurrence while the patient is in the hospital, because we pay for the care of those patients if they get them while they're with us. Okay. They look at all of the wounds on the patients who do have them. They measure them, they restage them and do the documentation, so all of that is done consistently. We don't measure the wounds every single day because you won't see progress every day. That's why we only measure them once a week. So, for your patients, you're going to have to describe the status of their skin integrity. So you need to be able to say that you looked over every single inch of your patient. Okay? If you see something that you suspect is a pressure ulcer, which is going to be where?
Bony prominence.
On a bony prominence. Okay? Then you would document it as such. If you see a wound someplace else, I would not call it a pressure ulcer. Unless we knew that the patient wore a brace and it was caused by pressure from the brace. Okay? But I'd be very careful how I documented that. All right?
Sue,
Yes.
when you say bony prominence, you're talking about bones that are close to the skin, right?
Yes.
At the heels, elbows,
Mhm.
shoulder blades. What about the back of your neck there?
Yes, if people had a bone that was there, yes. I've also seen them on the cartilage on the ears.
Oh, really?
We used to have a little retarded girl who would come in and her parents left her laying always on her back with a pillow, and she always had wounds in the backs of her ears.
So the head itself isn't?
The head doesn't usually, because you know there's not much tissue there,
Okay.
okay? There's nothing, there's skin, but there's not a whole lot underneath it. So no, thankfully, we don't usually see them there.
Yeah.
But I will tell you, there are patients that come in who've been neglected. You know, elderly people who've been cared for in the home by their family, and their family doesn't know how to do it. We see, you know, developmentally disabled kids that come in from home whose parents don't know how to take care of them, who have them. We don't see a lot of people come in from the local nursing homes or those places with pressure ulcers, because they are all under the same strict rules that we all are, and everybody works very hard not to have your patient get pressure ulcers. There's another kind of pressure ulcer, and I'm not going to talk about it a lot, that's called a Kennedy pressure ulcer. It is a terminal pressure ulcer. Usually happens on the backside of patients who are dying. Your skin is an organ and it fails just like everything else. And it will look sort of like a butterfly-shaped bruise on their butt. Those are unavoidable. And we finally are getting the third-party payers to recognize that that pressure ulcer is not anybody's fault. It's not, shouldn't be blamed on poor care. It just happens because the patient is failing. You know, but for a while, people were getting hauled to court because of that, because they were accused of giving poor home care when it wasn't the case at all. Okay? The other things you're going to look at is you're going to try to describe the qualities of the wound tissue. So you are going to document, you know, the size of any necrotic area. You're going to document the size of any area that has slough on it. And you are going to describe what the rest of the tissue looks like. Is it red, beefy, granular tissue? You should look at the dressing that's been on it. See if there's been any wound exudate, and describe the amount, the color, the consistency, and if there is any odor. And what do you think odor would indicate? Infection, right. A smell is one of the first signs that there is an infection there. The other thing that is a good sign of infection is an increase in the pain that the patient's experiencing. Now, some pressure ulcers are not painful. Some pressure ulcers are painful when we are doing things to them. But most of them are not achy, horrible pain like a surgical incision might be, okay? They're just painful when we're doing something. So we still need to assess that patient's pain and make sure that we're medicating them. A surgical incision is a little bit different. That is a wound that heals by primary intention. In other words, the edges are approximated, they're held together either by staples or sutures or steri-strips, and unless something happens in the healing process, that should stay that way. In a surgical wound, it is normal to see it be red after a couple of days. That is absolutely, positively normal. If it goes beyond 3 or 4 days, then you become concerned about the fact that perhaps it is becoming infected. But infection doesn't happen overnight, okay? The next day, it's going to look red, and that's normal. It's nothing to panic about. But then you need to watch it and be sure that it's not increasing in size, red-wise, and that it is not warm. That would be the other indicator, is if it kept getting increasingly warm, that it might be infected. Wounds like you're looking at on the slide now, they are wounds that will heal by secondary intention. In other words, from the bottom up, and they're probably going to form a significant scar. You know, these take forever to heal, some of them. You know, a lot of it is dependent upon the patient's nutritional status, their overall general health. If it's a patient that's got poor circulation to that area because of diabetes or something else, that wound is even going to be more difficult to heal. So all of those things are contributing factors. Pressure ulcers are not wounds that somebody's going to bleed to death from. You know, there's no concern about that. You know, there usually is very little bleeding from them unless we have just been in there to debride it. You know, nurses don't do mechanical debridement. That's done by a physician with a scalpel and tweezers and such, and often we take the patient to the OR so they are in a sterile environment. Nurses can do debridement with enzymatic ointments that we will put on them. And Santal is the one that seems to be the most popular right now.
With these pictures, are these like from earlier pressure ulcers with necrosis?
These, some of them are, yep. Now like, let's see. This one right here,
That's your slough.
that's slough, and that is all wound. That is probably gigantic, would be my guess. All of that area is what I was talking about. It's going to be boggy feeling. When you touch it, it's not going to blanch, and it's going to feel funky. Okay? This is totally necrotic.
Where?
So you can't tell how deep that one is either. This one looks to be pretty clean from what I can see here. You know, it's not too bad. I'm a little concerned about this area right there. These sometimes will have undermining, which means that, you know, the edges of the wound here, you can go underneath them some. I'll show you again in the lab. We've got a good picture of that. And sometimes, and this is what I would be worried about this, is sometimes they have tunneling. In other words, a sinus tract that you can put your finger right down. I had a patient once who had a pressure ulcer here, and you could put your hand right down her femur because it tunneled all the way down through. It was
How
gross.
do you not know that?
Huh?
How do you?
Well, truly they knew about this one. This lady was just in horrific shape, and unfortunately she wouldn't die. I mean, she just had every system under the sun failing except for her heart. And, you know, she came from a nursing home, but I truly think that they had done their best. I think she just had generalized organ failure except for that good, strong heart, and they could not keep her, you know, without those pressure ulcers. I don't think anybody was to blame at all.
What
Yes.
do they do if you have the tunneling? I mean, is that something that they can fix or?
It depends. We sometimes will pack them with, you know, gauze packing to try to keep it moist and dry down there. Really, what we do with most of these wounds these days is we use a wound vac on them. A wound vac is a device